Next talk is by Darlis, who's trying to demystify scapholunate instability. As always, mystique, Mr. Darlis.
Okay. Good afternoon to everybody. Thank you, Dr. Korobilias, and thank you, organizing committee, for the opportunity to be in the company of such distinguished panelists. I'll try in the next 15 minutes to do what people haven't done for a very, very long time. And I'm pretty sure that I will not be successful, but I'll try. So the scapholunate ligament, to paraphrase the Monty Pythons, is the holy grail of hand surgery. There are so many things that we've learned over the years, but also so many things that we still don't know. And when you initially see it in surgery, it doesn't look very impressive. Actually, in schematics, they have to color it to make it more impressive. But it does cause instability. And it causes a spectrum of instability, which starts from pre-dynamic dorsal wrist syndrome, what Kirk-Watson called, and then goes on to dynamic instability. That means that scaphoid and lunate spread apart under pressure and under grip. And then it moves to static instability, which is not only a permanent diastasis in the scapholunate interval, but also a flexion of the scaphoid and extension of the lunate, what we call the DC deformity, and also abutment of the scaphoid on the dorsal part of the scaphoid and lunate. And then eventually arthritis starts and progresses in a predictable manner, but this is not the topic of this talk. Early on, we understood that just by sectioning the scapholunate ligament, you could not produce that instability. You need other ligaments to be torn or attenuated in order to have instability. And from the 70s, we believed it was the long radiolunate ligament or the STT ligaments. And then in the 90s, the dorsal intercarpal ligament. And more recently, we discovered that the FCR dynamically stabilizes the scaphoid. So you need to have another component to this injury. The scapholunate ligament is well studied. It has a dorsal part that's quite strong, a very weak membranous part, and a volar part that it's not quite understood its role. It's not quite understood, or it's underestimated. Also, there's this lesion, there's this anatomic septum that exists between the scapholunate ligament and the dorsal capsule and was described by Manthulin, but we're not quite sure what its role is. In the last 15 years, there has been a game changer in scapholunate instability. And it's not time for drinks just yet, but it's what everybody should do as the last step of their diagnosis and the first step of their treatment. And it's what I think demystified this injury, and it's wrist arthroscopy, which helps us to actually grade and classify the lesions of the scapholunate ligament. So by the Geisler classification, we have type 1 tears that are just attenuation, type 2 that are just partial tears, type 3 that are partial tears that allow your probe to go through, and then type 4 lesions that allow your arthroscope to go between the scaphoid and the lunate, as in this example, from radiocarpal to midcarpal joint. Left is scaphoid, right is lunate, and right in front of you, you can walk through and see the head of the capitate. And sometimes the injury to the scapholunate ligament is not obvious at first sight. You have to actually probe to see a small tear, which is also significant. Midcarpal arthroscopy can help you. Normally, through the midcarpal arthroscopy, you have to have a steady interval. If you can pass your probe through the scapholunate interval in the midcarpal joint, you have a grade 3 instability. And likewise, if you can pass your scope from the mid-carpal to the radicarpal joint the opposite way from what we saw before, you have grade 4 instability. One thing that I told you is poorly understood is volar and osseous ligament tears. The more we scope these, we come across patients that do have instability on the volar part of the joint, but not on the dorsal strong part of the joint. And this is very well demonstrated here. The volar part is very mobile, whereas the dorsal part is less so. And there's no guideline as to what to do with these patients. There is the European Wrist Arthroscopy Association classification, and there's also the Garcia-Elias staging. But tell you the truth, this is very confusing to me. I'd rather think injuries as acute versus chronic, as dynamic versus static. Dynamic means that you do grip strength, grip view radiographs, and if you have a widening like on the left, then you have a dynamic injury. Dynamic and static is on the frontal plane. Reducible or irreducible is mostly on the sagittal plane. That means if you can reduce a DC deformity, it's considered reducible if you cannot close the gap. And finally, whether you have arthritis or no arthritis will determine what you'll do. The last two parameters are better assessed by arthroscopy. Now, what you do in an acute partial tear is usually arthroscopic reduction and K-wire stabilization. Here we have a sophus fracture, and as Alex Pagetakis told you yesterday, these are often combined with scapholunate ligament tears. This is the mid-carpal view for this lady. You can see that you can gap the scaphoid with your scope, so this is a significant tear and it needs to be taken care of. But you have to scrutinize every sophus fracture. Now, if you come across this kind of tear, this is a complete tear. It's a whole different animal. The state of the art still, and this is what it looks like from the mid-carpal view, this you have to treat it open. Still, the gold standard is open reduction, repair, and possibly a dorsal capsulodesis. But there are attempts at arthroscopic repair, both from the volar side or a volar capsuloplasty, and also from the dorsal side. The problem is that to do these techniques, you have to have a remnant of the ligament, both on the side of the lunate and on the side of the scaphoid. And this is not very often. Excuse me. This is about 20% of the patient. The rest of them will have an avulsion over one bone or the other. Yes, you can put suture anchor arthroscopically, but I think this is very advanced even for experienced arthroscopists. Now, moving on to chronic tears, if you have a chronic partial tear, then you have a slam dunk. You debride it and pin it, and most of the times the patients will do fine. The idea of thermal shrinkage still exists in the wrist. In shoulder, it's mostly gone, but in the wrist, you can actually immobilize, so you can thermally shrink tissue. The technique has changed a little bit. What we now do is what we call spot welding in different places in the scapholunate ligament. Now, when you have a chronic tear with dynamic instability, there are a lot of open options, and we'll discuss them in a little while. But there is also an arthroscopic option in which you debride the opposing surfaces of the scaphoid and the lunate down to bleeding bone, and then you pin it in an effort to create scar tissue between the two bones and stabilize them. This is not a panacea. Obviously, it's a 70-30 procedure, but every now and then you get this kind of result, and you return back to that. but it still does not burn any bridges. There are several other options. One is the Russell procedure, put a screw between the scaphoid and the lunate, or put a special device like in this SLAM method, or more recently, the internal brace reconstruction. But for the first two techniques, I don't think that everyone has copied the good results of the authors. And this internal brace concept is still under investigation. Ligament reconstruction or ligament anadesis became popular again in the past decade after it was originally described by Brunelli, and there are different ways to skin the cat. There's a lot of different ways to put your graft around the wrist. The most popular one is the 3LT reconstruction of Garcia Elias, but I'm afraid that the excitement about these techniques has died down as late results are coming through, and I'm not convinced that they're a lot better than what we used to have. There are attempts to replicate these techniques arthroscopically, but still this is a very difficult, technically difficult operations. What we prefer is this reconstruction with the palmaris longus graft that was described by P.C. Hohen. We'll go through that in some more detail in just a few minutes. But before that, we have to tell you what we do if we cannot reduce the static instability, or if we have arthritis. Most of our procedures are open, and they're usually partial arthrodesis or total wrist arthrodesis in worst cases. So this is a gentleman with a static scapholunate dissociation. You can see that there's also a DC deformity, and the idea is to pass to recreate both the volar and the dorsal part of the scapholunate ligament, and I think this is one of the advantages of the technique, that you recreate the volar part as well as the dorsal. The initial step of this procedure is arthroscopic, and I think it's the most important, because you have to actually clean the scapholunate interval of scar tissue. One of the reasons that a lot of reconstructions or ligament reconstruction or tenodesis fail is that you fail to adequately clean the scar tissue that develops between the scaphoid and the lunate, especially in the volar part. And you don't actually reduce the two bones, you compress the scar tissue. So you have to take your time and actually clean and make sure that there's nothing connecting these two bones before you try to do you actually see the flexor tendons before you make sure that you get the reduction right. And after you can do the reduction, you put guide wires in the scaphoid and the lunate in angles, so that when you reduce them, you will have your deformity reduced, and then you pass palmaris longus, usually graft from dorsal to volar, and then back again dorsal, and just put a knot on this and secure it. And this is how it looks immediately in the OR. And after you remove the stabilizing pin, you can see that there's some residual gapping, but the reduction in the sagittal plane is correct. This is how it looks on MRI. And this is our first patient. I think it's like 7 years out now. It's the left hand. You cannot, on X-ray, you cannot actually tell. And he came in for another procedure, and he has this kind of motion, which is, I think, great for scapholunate reconstruction. This is a colleague, a neurosurgeon. He had his right hand. He has a reconstruction on the right hand, and scapholunate ligament repair, primary repair on the left. There is still some gapping, but the alignment is maintained, and he was kind enough to send us a video of his current range of motion. You know, neurosurgeons use caissons, and they're very tough to squeeze, and he's actually doing fine. But in general, if we consider every goal of treatment that we have in these injuries, I'm afraid that there's no procedure that can reproducibly meet all these goals. So the Holy Grail still remains elusive. What are we doing in 2020? First, we have to arthroscopically assess the patients, whether you do an arthroscopic procedure or not. There is skepticism about ligament reconstruction. There is an interest in the volar part of the scapholunate ligament. Most people will do a dorsal intercarpal capsulodesis when they do an open surgery, even as an adjuvant. And some people are revisiting the notion of scapholunate arthrodesis with newer material. And with that, I want to thank you, and I want to acknowledge the president of the Hand Surgery Society, Nick Zagoreos, who has been my partner in crime in this quest for the last 7 years. And since I'm the next president of the Hellenic Microsurgery Society, normally at this point I would be announcing where the our next Congress will take place. We've been planning this with Philippos Giannoulis, which is the next president of the Hand Surgery Society, for over 1 year now. And I'm afraid we're still in a standstill. However, I can give you a teaser. If things go our way, we'll be celebrating the bicentennial of the Greek Revolution by the sea, sipping cocktails. And let's keep our fingers crossed about that. Thank you.
Okay, okay, Nikos, thank you very much for this difficult issue and controversial issue in terms of treatment by the scapholunate instability.